So I think, CAR T cells and bispecifics have both really revolutionized the treatment landscape for the aggressive B-cell lymphoma patients in the relapsed refractory setting. Initial approval was in the third line for CAR T cells, then they moved into the second line, and there are ongoing trials in the first line. This is very exciting. We have the ZUMA-12 data with a 3-year progression-free survival of close to 75% for patients with an IPI score of 3 to 5 or double hit, triple hit, and an interim PET scan with a score of 4 or 5. So patients meeting that criteria were enrolled on this first-line trial, and kind of based on this data, we're very excited about the ongoing randomized ZUMA-23 trial, which is comparing upfront axi-cel with standard of care R-top-like in patients with an IPI score of 4 to 5. So I think, one of the definitely advances we may see in the future is moving CAR T cells and bispecifics into the frontline setting. There are also very exciting trials also open at our site exploring the role of bispecific antibodies combined with an immunochemotherapy backbone in the frontline setting. So now we know that they're have curative potential in the relapsed refractory setting, but I think in the future, both of them will probably have a role in the frontline setting, bispecifics for sure. And this will increase definitely, the rate of durable remission, so it's even the first line. I think it will also be interesting to observe if this can somehow impact how we treat them in the relapsed refractory setting. If patients relapse with a CD19 or CD20 negative, for example, lymphoma, and then, we have perhaps a lower number of options we can offer these patients in the relapsed refractory setting. So just lots of questions coming up. And I think, they have already revolutionized the relapsed refractory setting with their curative potential, increase in, the rate of patients who are, salvaged in that second, third line plus setting. Now in the frontline setting, it will be exciting to observe where we can take that, classical 60% of cured patients with the R-top-like regimens, with CAR Ts, with bispecifics, and what happens when these patients, relapse. Will we be challenged on salvaging these patients with, novel treatment regimens?